So thanks, Catherine, for the introduction, and hi, everyone. I'm very pleased to be here to discuss with you today about the findings from our research project that looked at practices, policies, and of healthcare and return to work for persons compensated following a work injury. So the presentation plan, there'll be 3 segments. So basically, I'll just give a brief context and background about the research project. Then the main part of the presentation will be to present you the findings from our empirical project, a qualitative project in 4 jurisdictions. And then we'll have the discussion and questions right at the end with Dana that presented marvelously just before. So just to give you a little bit of context, this project was done as part of my postdoctoral training. And during this postdoc, we decided to look at policies that provide guidance and direction to frontline healthcare professionals working with injured workers. And we decided that we would look more specifically at workers with MSK injuries or musculoskeletal disorders, as they are a huge part of the people compensated by workers' compensation boards. So I'll move on to the research project. Oh, sorry. So as you all know, basically, if you're here, it's because you know that work-related injuries are a major public health issue. They affect the physical and mental health of workers and lead to activity limitations and restrictions to their social participation. They can lead to prolonged absences from work, but also from their activities and leisures. The work-related injuries and musculoskeletal disorders generally account for the majority of claims to workers' compensation boards, and that is why, in this case, we were interested in those disorders specifically. For people with a work-related injury, healthcare providers are really important persons. First, they are the first point of entry for workers to access benefits and medical care. And they are also the ones who will provide care and guidance throughout the recovery period following the injury. As part of this postdoctoral project, we've done right at the beginning a critical interpretive synthesis that was specifically looking at first-line healthcare providers and how their role in practices can affect workers. This has been published, so you can have a look, and we might give you the link a little bit later. But following that work, we saw a gap that is in workers' compensation systems literature. There seems to be little comparative work that has been conducted on the ways policies from WCBs influenced healthcare providers' practices and how these can in turn impact workers' trajectories. So our objective and the research question was to explore how workers' compensation policies related to healthcare provision, more specifically for workers with MSDs, can affect the delivery and trajectories of care for injured workers. And we decided to do that in 4 specific jurisdictions. We wanted to have this comparative aspect to the work, so we decided to look at Ontario and Quebec because the project is situated in Ontario and Quebec, the larger project, and we are researchers from Ontario and Quebec. We also decided to look at Victoria, so the state of Victoria in Australia, and Washington state in the United States. We've chose those 4 jurisdictions because on an overarching level, there are similarities between those jurisdictions. They are all cost-based systems and mainly no-fault system, except from some little differences in Victoria and Washington that I won't speak about now. But what was very interesting and what we were looking for is that workers' compensation laws and WCB's policies are really different in terms of healthcare provision for injured workers in those 4 jurisdictions. And that is why we decided to explore them more specifically. How did we do that? So we used a qualitative empirical design that was mainly informed by framework analysis, which is a qualitative methodology for policy research, and also aspects of grounded theory. The data collection was semi-structured interviews with key informants, and the interview guide was based on the critical interpretive synthesis of the literature I just spoke about at the beginning. And there were really different topics covered in those interviews that have about half an hour or maybe a bit more for all the key informants. And the topics were, we discussed the influence of existing policies on the work of healthcare providers with injured workers. We looked at the influence of the philosophy of care of providers and the practice environment and care provided. We also discussed about recent or upcoming changes in compensation policies. These interviews were mainly done in 2019. So mainly there haven't been a lot of huge changes in those 4 jurisdictions, but there might be, as Catherine explained at the beginning, in Quebec with the new bill that has been proposed. We wanted to have a diversity in the types of participants and key informants we included. So we chose to talk to key informants from 5 different categories. And I know that the titles are long, but I'll try to explain a bit more who were these people. So we try to speak with people that are workers' representatives or persons working in an injured workers organization or workers support group or community clinic. We also discussed with the representative of healthcare profession or persons in a leadership position in a healthcare professional group or association. We discussed with representatives of workers' compensation boards or person in a leadership position or committee at the WCB. We spoke with employer representatives or person in a leadership position in an employer organization or employer support organization in occupational health mostly. And researchers studying the field of workers' compensation policies and or healthcare services in each of the 4 jurisdictions. So we really aim to have a good representation of these 5 categories of person in our 4 jurisdictions. So in the end, we did interviews with 42 key informants, so a lot of people. You can see that they were separated in the 4 jurisdictions, and we wanted to have representation from each of those 4 jurisdictions. This is a table that presents more shortly the titles of the group, but the workers, healthcare, WCBs, employers, and researchers groups. So you can see that also it's separated between those groups. For the analysis, so I re-listened to all the interviews. I wrote memos right during the interviews, at the end, and while re-listening to them. And I did the first analysis really based on this listening and first reading of the transcript. All content was then imported in a support software for qualitative research, which was in Vivo. And with this, I coded inductively all of the transcript for all interviews. And we really use matrices and tables after that to compare jurisdiction, to compare participants group, their views, which was a hard task. But throughout this analysis, I spoke regularly with my 2 wonderful supervisors, so Catherine Littell, who spoke at the beginning, and Ellen McKicken, to come up with those results. So I'll jump into the results right now. So what I'll present today, mostly I will speak about the point A, which is with this project, we were able to explore the different ways in which WCB's policies frame healthcare provisions. And what I'll present is a part of all the different things the stakeholders, key informants discussed with us. But today, we decided to really focus on the different ways in which WCB's policies frame healthcare providers' work. And I'll spoke a little bit at the end about some of the tensions that were uncovered in the discourse about healthcare provisions. And you'll see how it relates with point C. So we'll start right away with the ways in which WCBs frame healthcare. So we've seen that there's really 2 different overarching mechanisms in which WCB's policies and WCB's laws will frame health or influence healthcare provision. So to the left here, you can see that the WCB's policies, WCB cannot be in the office of the healthcare providers, but there's different ways in which WCB's policies will try to impact or influence the way healthcare providers practices their behaviors with the worker, and they'll do that with different ways that I'll explain in a minute. On the right side, there's also, it's a little bit more higher level way of influencing healthcare. So WCDs will try to put on some mechanism and policies to have a larger or overarching control over the trajectory of care of the workers, accepting some sort of things, refusing those some other things, and also sometimes predefining the pathways of care for injured workers, which you won't see, for example, if someone is treated by their own means, in a public system or by a private insurance. So we'll look at a bit more about the first one. So the framing the day-to-day healthcare practices and behaviors of healthcare providers. In the interviews, informants really spoke about two different things that we classified. First, some ways are to use clinical guidelines and non-economic inducements. And another mechanism was to use monetary incentives to change the behaviors. So we'll speak about the guidelines first. So in Washington and Victoria, clinical guidelines were used and discussed by key informants. So in Washington, these care guidelines, there's many of them that have been created by an insurance medical advisory committee, which is mainly appointed by the WCD. These care guidelines provide guidelines to healthcare providers about the type of care they should or shouldn't provide with the workers, some things they can or cannot do. And it was interesting because these care guidelines tended, according to some key informants, to be more and more used as a prescription and not as a guideline. So one labor representative in Washington said, and so the department can talk about, whether or not they want to create incentives for doctors to adhere closely to the medical guidelines, which they do have. They do have incentives for that. We don't think those guidelines should be used to overturn the legitimate medical opinion of an attending physician. And if you do want to challenge a decision of attending physician, that's what independent medical exams are for. It shouldn't be kind of misrepresenting the guidelines as anything but guidelines. So this was for Washington. In Victoria, the use of guidelines, the main guideline that frame healthcare provision in the WCB system is called the clinical framework. This clinical framework, it's much less precise, according to key informants, than what it is in Washington. So this framework has like 5 broad overarching objectives that healthcare providers should achieve in their care for injured workers. This clinical framework was perceived as less prescriptive than in Washington, and it was mainly endorsed by the different key informants that I spoke to because of this less prescriptive nature, and also because it was endorsed by larger professional associations in the country. In Ontario, people didn't discuss care guidelines more specifically, but they discussed the programs of care that influence the care of workers that I'll discuss a little bit later in the presentation. And in Quebec, they didn't really specifically discuss about having care guidelines influencing the care of workers. So in all of the 4 jurisdictions, what was also very discussed to try to change the practice, the behavior of healthcare professionals is training. So a lot of key informants started to talk and discuss about how they had tried to use training to modify behaviors, to have healthcare professionals know more about the workers' compensation system, to treat in certain ways. But what's interesting is that one of the bottom line from a lot of key informants was that this didn't seem to work very well. So training, providing those kind of trainings to healthcare providers didn't seem to be really effective in changing practices and behaviors. One participant from Australia said, I think we haven't really seen behavior of general practitioners change a lot in the last 5 or 10 years. You have to do all sorts of other things to change behaviors. So there's quite a few people at the moment sort of in senior policy roles here scratching their heads about what they can do to try to get better engagement from the general practice community here. And because of the fact that key informant discussed that training doesn't seem to really influence healthcare professional practices, WCB's policies have no choice than to use other means to influence practice behaviors. And this is our second point here, which is the monetary incentive to change healthcare professional behaviors. So I'll discuss about some of them right away. In Washington, they use monetary incentive really to reach 4 administrative quality indicators. So people in Washington told me that the WCB has mandated a committee to develop like 4 administrative quality indicators that they wanted healthcare providers to follow. And so they give monetary incentives, so they reimburse more the doctors if they do those, they complete those administrative quality indicators. And just to give you an example, the first indicator is to fill and send the initial claim form within 2 days of the injured worker's visit to the doctors. Another administrative indicator is determining at the first and second visit for workers on lost time what they can and cannot do, and fill an activity prescription form to do that. And the third one was having somebody from the doctor's office to communicate with the employers. So they've decided to, they've evaluated, the WCB has evaluated that these were the, they call it quality indicators that they wanted doctors to reach, and that's how they get to reach them. In Victoria, the monetary incentives was to get people trained. So even though they said the training doesn't really work, they wanted to have a specific kind of healthcare providers, so the physiotherapists, to be trained at least from the basics of the compensation systems. So they provide higher reimbursement fees for those professionals when they have completed the training. And that was an example where the WCB had collaborated with a university because the university had created that training that was then used by the WCB in Victoria. Here in Victoria, we have a structure where there are physiotherapists who can do extra training and can then effectively call themselves occupational physiotherapists. And they have a different fee structures when they're treating workers' compensation. And we put together an online package. The idea being that physiotherapists would have to complete the training to qualify for that title and be able to bill for slightly more for their services when treating compensable clients. So this was a researcher discussing about this monetary incentive that WCB has put in place. In Ontario, key informant really discussed about some monetary incentive to return people back to work. And they were created mainly by the programs of care. So the fact that the providers, for example, will be given only 8 weeks and an amount of time to provide care, but also with decreasing fee scales if the person doesn't go back to work as fast as the board would like. So someone from a workers group in Ontario said, in these physicians program for treatment of MSK injuries, they will impose sliding scale fee structures that pay less as the treatment takes longer. They say that it is paying for results, meaning they're paying less if doctors are not being successful, or physiotherapists or chiropractors are not being quote unquote successful in getting workers out of treatment and back to work. We say they're disincentivizing longer term treatment. Finally, in Quebec, doctors spoke about the fact that they were reimbursed for filling out compensation form, which was kind of an incentive for them, but didn't really speak about specific monetary incentives to change their practice. The second overarching mechanism that I discussed at the beginning of the results is the way WCB's policies try to control the trajectory of care of the workers. And this is very different, you'll see in the 4 jurisdictions we've looked at. So one of the ways they do that is by standardizing and predefining some care pathways. And another way to do that is how the WCB policies will vest power in healthcare providers or not. And I'll explain that to you a little bit more. So first, for standardizing and predefining care pathways, they were strong some key informants were really strong in their opinions about that. So one researcher in Washington said, I guess the one thing I would say is I don't think people in the healthcare system quite appreciate the importance of standardizing care and having defined pathways. I think people are still in this mode of thinking that making individual decisions for patients based on what they think is best, rather than trying to have a more standardized approach to everything. So there were some nuance in the way they would talk about using standardized care approach. Some were more for using those approach at the beginning of the injury and the beginning of the compensation process. For example, the importance of flagging serious injuries right at the beginning. Also, the importance with those care pathways to refrain doctors, for example, to refer for X-rays, MRIs, or rapid surgeries that were not needed. And this was specifically true for persons I spoke to that were in Washington or Victoria, where the healthcare private system is very strong and where healthcare providers can visit surgeons in the first instance. So the first line healthcare providers could be a surgeon, and where they could decide to do a surgery right away instead of maybe starting with more conservative care. Some key informants also spoke about the use of early identification strategies to detect risk factor for chronicity. So this was a thing that was really discussed by a lot of key informants. And I'll give you two examples of the different ways we decided to do that in two jurisdictions. So in Washington, they've developed an early identification tool to detect chronicity. And they base this tool on an existing tool that already exists in the scientific literature, more largely for MSK injuries. They've developed the tool, they tested it with hundreds of workers, and then decided to implement it at the WCB. This tool is available online if you want to look that up. In Quebec, the approach was much more different. So one key informant in Quebec was speaking about the fact that they used kind of a detection tool at the CNES to see where the worker would fall in terms of chronicity and risk factors for chronicity, but this tool is not available to the public. The researcher didn't know if it had been validated or not, so probably not. And so the process was much less transparent in this way. Also, another thing that was discussed a lot was the type of paradigm used by the different key informants. So one person from the WCB in Washington said, workers' compensation tend to focus on because of the forces that make money in workers' comp. Nurse case management companies or specialists that do surgeries, they tend to focus on what they call disability management as opposed to disability prevention. And the thing is, about disability prevention is if you don't do something and realize what's going on in the first weeks and months after an injury, you're not going to be successful. So this approach and this way of saying that we should prevent disability instead of manage was discussed in Washington. And an example I can give you for this jurisdiction that really emphasized that maybe is that in Washington, they've developed a policy recently about opioids, a very stringent policy where doctors cannot prescribe more than 3 days of opiates to injured workers when they visit the doctors. At first, the labor movement, the key informant I spoke with, were really against this measure because it was really stringent in defining care treatments for the workers and the possibility to be to get more pain with the medication and to have appropriate medications. But the WCB has shown that it has considerably reduced the number of deaths in Washington of injured workers following this policy procedure. So some key informants said they saw this in a positive way. So this is kind of a counter example. So usually key informants discuss about the policies being too stringent and too restrictive, which was really seen negatively. But for the opioids, the disability prevention aspect had seemed to work according to many key informants. Another way that WCB's standardized care for patients, a very good example was Ontario. Ontario, as I spoke earlier, has programs of care. These programs of care really define care pathways for workers. So they'll go in a low back program, a shoulder program, an MSK program. And these have specific length of times, about 8 weeks. If the workers doesn't recover, then they'll usually send them to a specialty clinic. So the care pathway in Ontario really is defined. Some researchers and some people from employers group perceive that as positive, but people from the workers group, workers advocacy group, and other researchers thought it could be deleterious for the workers because of the too much standardization. The last aspect I want to discuss about is the power vested in healthcare providers. So in Ontario, Washington, and Victoria, different key informants really spoke about the fact that healthcare workers wanted to provide appropriate care for workers, but they couldn't do it appropriately because they didn't have the power to do it. So I'll share some quotes about that with you. In Ontario, someone from a workers group said, well, the policy on the surface says it takes into account what primary care providers say to the board. However, in practice, their role is minimal. They're really not listened to other than for the initial reporting, the Form 8. What they say after that is mostly irrelevant to the system. In Washington, someone said, it was a healthcare provider's representative, you know, the claim manager really calls a lot of the shots. So they're in a very important, powerful position. And I was thinking that they really do need to have a sensitivity training because they'll close claims, they'll refer for these independent examinations, etc. In Victoria, someone said that it was a researcher. I think it's just more about the ability to be able to say a particular service is needed and not necessarily have to go through an administrative process that have to be approved. So I guess it's an acknowledgement of the expertise and the ability to identify factors that lie outside of your own expertise. And key informants from Washington and Victoria really gave examples. A nurse practitioner in Washington was saying, I wanted to prescribe this particular antibiotic after this MSK injury, but I couldn't because it wasn't approved or pre-approved by the board. So the power that were vested in caring appropriately for the workers was really low in these examples. In Quebec, those concerns were not voiced by the participants. So as you might know, the opinion of the treating doctor is binding in Quebec for 5 distinct elements, and that is formally written in the compensation law. So the power really was vested in the doctors, which was perceived mainly positively by a lot of the key informants. However, in Quebec and in jurisdiction with fee-for-service healthcare provisions, a lot of participants from the employers group wanted to have more stringency over the number of treatments allowed and the trajectory of care. And some of the WCB's policies that they approved of was the use of clinical reviews to see after a certain number of time how many hip treatments are still needed, for example, and the use of more firm or standardized, again, consolidation charts to cut benefits after a certain time. So as you can see, and I hope it showed in the way I explained the last part, is that there were a lot of tensions and opposing discourses sometimes about healthcare services, depending on who I was speaking with. And I'll just try to shortly describe those tensions so that you can understand more the challenges in writing and informing WCB policy. So there really was a tension between the judgment and the decision and the power to vest in healthcare providers, as we just discussed. So different key informants wanted to have more WCBs that makes a close supervision or that is overseeing the practices of healthcare providers, and others were saying it's really important to have confidence in the judgment of healthcare providers and not to impose too much judgment and decisions from the WCB part. There was also a tension between different paradigms of the stakeholders. So some really had a biomedical paradigm where the person has a lesion, this lesion needs to heal. We can determine specific healing parameters for this lesion. Whereas other stakeholders were saying we should see the broader picture. So there's the lesion, okay, but there's limitation activities and restriction of participation that are much more complex than the actual lesion, and that results from multiple factors like workers' mobility, for example, as Dana discussed. So this was more a disability paradigm. There was also attention when discussing return to work. So different stakeholders were discussing about the fact that healthcare providers should focus on the medical aspect. So they're good with the medical, the biomedical aspects, they should focus on that. Whereas others were saying, we should try to get more education. We should try to have healthcare providers take more action into the return to work, provide advices, refer to occupational health doctors, speak with employers. So this was a tension that was seen a lot of times. And finally, the return to work philosophy of those different actors. So some key informants had a better at work philosophy where they spoke about the importance and the priority for people to get back to work fastly after the injury. And others were really discussing the importance of having room for individualized care, addressing complexity, and that faster return to work was not always the better. So in conclusion, the interviews in the 4 selected jurisdictions really allowed us to explore the complexities of care for injured workers supported by WCBs, and a better understanding of the different ways. You've seen it's really different in the jurisdiction of the ways policies frame workers' care is important to clarify the impact of current policies on workers and to inform the development of future policies, such as it is discussed at the moment in Quebec. Of course, there's opposing tensions in several spheres across group, but I think that we shouldn't put aside these tensions and just say they're always opposed and that's like that. I think that this is an example of the ways we should be exploring these tensions, and that can help us present a nuanced portrait of the healthcare services offered to injured workers, and also bring to light the various values that underlie policy choices. And having clearer values explicitated could help in informing those policies. So my last word will be to say that I think there's an importance to continue comparative research across jurisdictions and to learn from the various initiatives in the policy realm and the negative impacts, but also the positive impacts they could have on workers' care. So I really want to thank all the participants in the project, and I think that there might be some participants I hope that will listen to this webinar. Our contacts in the 4 jurisdictions that help us get to those key informants, Ellen and Catherine, my supervisors, and my scholarship from FRQS in Quebec, and the Canada Researcher in Occupational Health and Safety Law. So thank you so much, and I'm eager to discuss with you a bit more in the next minute.